On this episode of the ASC Podcast with John Goehle, we discuss the latest news, including ASORNs Recommended Practice regarding the use of multi-dose ophthalmic medications, key findings in a recent Avanza Study on Hospital ASC Investment, news about CMS increasing dental surgery reimbursement for Hospital Outpatient Surgery Departments, and in our focus segment, discuss interoperability in the Ambulatory Surgery Center with Lindsay Hanrahan SIS Vice President of Product Management.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com.
Welcome to episode 165 of the ASC Podcast with John Goehle for September 5th, 2022, recording from our studio in Spencerport, New York. This is Sue Cronkite, Chief Researcher for the ASC Podcast with John Goehle and Senior Nurse Consultant for Ambulatory Healthcare Strategies. The ASC regulatory environment is extremely dynamic, and the material provided in this episode is based on information available as of the date of the recording. Joining me is John Goehle, the owner of Ambulatory Healthcare Strategies. He is recognized as one of the nation's leading experts in the ambulatory surgery industry. Mr. Goehle is the author of over 10 books on the ASC industry and a frequent industry speaker on regulatory, accreditation, and finance issues.
So I feel like we've spent the entire last week in the studio here.
Mm-hmm. We did.
We did. And we just finished the ASC Administrators Boot Camp. This would be our 7th boot camp and 4th ASC Administrators Boot Camp. And as always, it's very exciting and very interactive experience. We really enjoyed, we had a lot more interaction with our staff this time than we've had in the past. We've had more people being able to join us now with, we'd like to announce we do have a new employee, Donna Macchio, former administrator of a surgery center in Westchester, New York, and she joined us about 2 weeks ago. And she joined us a couple times during the boot camp there to give her insight and things, and we really had a lot of fun. And with this group, we now have a total of 175 graduates of our boot camps over the past 2 years. That's pretty amazing when you think about it. And as I said, that was the 7th boot camp that we've done, and we already announced the 8th boot camp, which will be the ASC Director of Nursing Boot Camp for nursing leaders in the ambulatory surgery setting. Like all of our industry-leading boot camps, the Director of Nursing Boot Camp includes reading materials, virtual mentoring consultations, and an intensive 4-day virtual conference that's going to be presented October 25th through the 28th, 2022. And Sue, one thing that we always have to emphasize to people, since it is virtual, of course, which means you don't have to travel to go to the conference, but people still ask, do I have to be there the whole time? And while it's best if everybody is there the whole time, we do record the boot camp, and as a result of that, people can go back and listen to the boot camp over and over again. If they missed anything because somebody came into their office and bothered them, which of course is the nature of our business, they can pick it up later. So that's a very important thing to note, that you never miss anything when you're taking one of our boot camps. So for more information about the Director of Nursing Boot Camp in October 25th through the 28th, go to our website at ascpodcast.com.
And in just about a week, our September 2022 ASC Finance Accounting and Reimbursement Seminar will be, it's a partnership with Christina Benton. This is the ASC industry's only dedicated finance, accounting, and reimbursement seminar. And this year, 2022, will be its 3rd year. We'll be discussing various aspects of finance, accounting, and reimbursement in the ASC setting. It's ideal for anyone who's interested in understanding basic finance principles, as well as those that know finance but want to learn how it differs in the ASC setting. The program is also designed to assist those that are seeking CASC certification to understand the finance section of the exam.
And in about 2 hours, we're recording on on Labor Day here. In about 2 hours, I hop on an airplane and head for California for the California Ambulatory Surgery Association's 2022 annual conference at the Hyatt Regency Indian Wells Resort and Spa. If you haven't signed up already, make sure you do. I'm going to be presenting a 4-hour finance boot camp on Wednesday. And Sue, I'll be recording as many interviews as I can while I'm there. You're not going to be joining me. You're going to have enough to keep you busy here, I'm sure. But I'm very much looking forward to it, even though it's going to be in a very hot part of California. Yes. So I'm not sure I'm really looking forward to that, but I'll stay indoors the whole time. But
the conference is always wonderful there. So
absolutely.
It's just
though you and I have actually never gone to this resort. We've been to two of the other locations that that CASA goes to, but this is the first time out in Palm Desert. So
just in general, the California conferences tend to be really good. They have a lot of good information.
Right. And we have a lot of news this week. And we'll start with the American Society of Ophthalmic Registered Nurses, better known as ASORN. They have a recommended practice regarding the use of multi-dose medications. And actually, it's from January of this year, but it was noted that our listeners might want to be made aware of it. So specifically, this document, which I'll give you a link to, the purpose was to establish guidelines for the use of multi-dose ophthalmic medications. And this, as we well know, is an ongoing issue with many surveyors and states and with the accreditation organizations. And the document is meant to give some significant guidance to ambulatory surgery centers. I don't think, Sue, any of this information is unknown. I think everybody kind of follows this, but I'm not sure that it's always been in writing as specifically as it is here. So let's just go through some of the things that are in there. And as I said, I'm going to provide a link to it. So eye drop medications labeled as multi-dose may be used for more than one patient if and only if aseptic technique and standard precautions are followed. Any medication labeled as single use must be discarded immediately after use on a single patient. And this is obvious, but I'll tell you, we've had situations, or I've been on surveys where, there's been an immediate jeopardy called because the surveyor noted that in ophthalmology that somebody was trying to use a single dose on multiple patients. And then they outlined the procedures for using multi-dose ophthalmic drops. And it reiterated the 3 checks for medication confirmation, which is when reaching for the container, after obtaining and comparing the container with the physician's orders, and when replacing the medication in its storage location or before administration to the patient.
And, of course, the 7 rights of medication administration, which are the right patient, the right medication, the right dose, the right time, the right route, the right reason, the right documentation, and the right response.
And of course, Sue, those are things that you as nurses know, right off the bat, but it's something that many administrators probably are not familiar with. I was not aware of that, so it's a good thing to remember.
And it's always good to repeat anyways, because they do keep adding to these.
Yes.
There was once, the 5 rights. And of course, you always wash your hands before administration of medications. If you're instilling more than 1 drop, utilize appropriate technique to prevent contamination, such as not touching the medication bottle after patient contact unless you perform hand hygiene before that. Before administering ophthalmic drops, remove the top of the bottle and place the cap side down, not bottom down, on a clean surface. Use an applicator or have the patient gently retract their lower lid with a clean finger, instill a drop into the cul-de-sac that's created. Never touch the tip of the bottle to the patient, lid, lashes, or the surface of the eye, of course. If administering ophthalmic ointment, use an applicator or have the patient gently retract the lower lid with a clean finger. Hold the applicator end of the tube close to the eye and squeeze out a ribbon of ointment into the inferior cul-de-sac. If administering ophthalmic drops and ointment at the same time, the ophthalmic ointment should be administered last, just so it doesn't kind of block the absorption. Replace the top of the bottle or tube using aseptic technique. All individuals need to have competencies demonstrating their ability to carry out the steps as outlined above. And we're putting a link to the full document there.
So again, I think the surveyors in particular are going to be observing the technique during a survey, and of course they're going to want to see the competencies in the employee files. Mm-hmm.
And it makes sense because even though all of this is common sense, it's just like when you're first learning how to act around a sterile field, it can take a little bit of practice to kind of do it all smoothly.
Right. And then there was an interesting news release from Avanza Healthcare Strategies and their president, Joan Goehle. The key findings from a recent survey of hospitals related to their investments in ASCs included that hospital systems are expanding their ASC portfolios, and many are converting hospital outpatient departments to ASCs, which seems surprising to me, Sue, because the reimbursement in an ASC is lower than the hospital outpatient departments. But then again, hospital outpatient departments that were created off-site after about 2017, I think, somewhere around there, 2016, were no longer reimbursed at the higher HOPD rate. So perhaps they're just finding that the ability to have outside investment in the ASCs is the advantage of moving that over. And then it also found that more than 80% of hospital systems surveyed have one or more of their ASCs as joint ventures with physicians, and more than half are allowing employed physicians to invest in their ASCs. And then most importantly, or most interestingly to me, was that third-party management and partnerships continued to decline. And the Avanza founder and president, Joan Goehle, noted the following. It comes as no surprise to see our new survey indicate that hospital systems are pursuing a variety of ASC initiatives, often in partnership with physicians, that will allow them to broaden their surgery center and outpatient portfolios. As surgical care continues its migration out of the inpatient setting, hospital systems are recognizing the need for at least one ASC and increasingly multiple centers in their portfolios. Goehle also points to the maturity of the ASC industry, and she noted that in the early days of ASCs, management services were often a necessity to running a viable surgery center. But thanks to the proliferation of support services and technologies for the industry and growth of those professionals with ASC experience, the need to give up valuable equity and enter expensive management agreements is no longer a requisite for ASC success. And I've provided links to the report and to Avanza on our show notes. So, Sue, as they're talking about this, of course, we have a bunch of hospitals. Ambulatory Healthcare Strategies has a bunch of hospitals they're working with their ASCs. So, and we're not a management company, so it's not a big surprise as they find that they can leverage less expensive systems or less expensive options such as regulatory consultants as opposed to using a management company who takes a very big cut out of the profits there. So interesting study, and definitely provides us a good indication of what's going on with regard to ASCs and hospitals. And then CMS issued a proposed rule that would improve access to dental surgeries in hospitals. So, Sue, this is kind of good news and bad news. Like, the good news is that they're looking into reimbursing hospitals at a higher rate, but our ASCs are not yet included. So a proposed rule from CMS would increase the facility fee for dental surgeries performed in hospital outpatient operating rooms, thereby increasing access to dental rehabilitation surgery for patients who need extensive dental procedures performed in an operating room. And this has been an ongoing issue with dental surgery in hospitals and ASCs, as these procedures generally have been reimbursed very low, like about $100 in the ASC setting. And the dental associations had asked CMS address the dental community's significant concerns regarding pediatric and adult patient access to dental rehabilitation surgery in the hospital outpatient ambulatory surgery center locations. The dental organizations noted that limitations in access have been exacerbated by the COVID-19 pandemic, primarily affecting high-risk Medicaid and commercially insured patients who require an operating room setting when receiving extensive dental procedures due to their particular medical conditions. And what they propose is to change the ambulatory payment classification, the APC, from CPT code 41899, which is an unlisted procedure for dental procedures, and it's the code that's frequently used by hospitals and ASCs to bill the facility fee in the operating room. And the code is currently assigned to APC 5161, which is a level 1 ENT procedure, and that reimbursement rate is approximately $200 in the ASC setting. And that rate in no way reflects the average cost of the dental services it's meant to cover. CMS is proposing the move to code to APC 5871, which is dental procedures, which would raise the Medicare facility payment rate associated with this procedure code from about $200 to almost $2,000. If this regulation is finalized, it would be effective January 2023. And this increased facility fee would apply to dental OR cases taking place in the hospital outpatient setting for Medicare patients when that CPT 41899 is billed. Many states, as we know, use Medicare billing codes for Medicaid services and use the code's assigned billing rates to guide Medicaid reimbursement. Now, keep in mind that this is currently only in the hospital setting. The American Dental Association is trying to get this approved for the ASC setting also, which, of course, will result in a lower reimbursement rate, but still higher than what they're getting right now. Probably about half of that $2,000 that we mentioned earlier, but it's still a significant increase. And in ongoing conversations with CMS and Congress, the dental groups will continue to pursue efforts to establish a new HCPCS code for use with the ambulatory surgery centers. And I do want to make it clear, I got this information from the American Dental Association website, and I'll provide a link for that.
I saw an article in OR Manager from August 19th about unprofessional physician behavior. And they define unprofessional behavior as rudeness, refusal to practice handoffs or observe protocols, extreme delays in response, jousting, and failure to adhere to safety guidelines. And they found that only 5% of physicians account for 35% of patient complaints and 50% of claims dollars. A really important finding, I thought, is that those same physicians are more likely to have poor patient outcomes. So it's more, I know a lot of people joke about difficult physicians or they have a hard time, but it's really more serious than that, than just getting your feelings hurt or having a stressful day at work, which is serious enough in itself. But it's something you really have to address, especially knowing that it could be affecting patient care. And interestingly, just 3% of physicians account for half of all coworker complaints. So there's really very few out there that are causing this problem. Vanderbilt Center for Patient and Professional Advocacy has developed a couple of programs to address these issues. The basic intervention is just having a peer rather than an authority figure have a casual conversation over a cup of coffee. They're calling it, just a cup of coffee conversation. And the peer should just be trained to be empathetic and non-judgmental so the person they're speaking to doesn't feel attacked. And most, they found, improved their behavior after just this one conversation. When it didn't improve, they recommended a tiered approach consisting of a second, longer peer conversation, followed by an intervention by an authority figure, if that's needed. The next step would be moving into disciplinary action. And it's important to have wellness resources available to staff also in case the behavior is being caused by stress or the physician is experiencing burnout. And the success rate for these programs is around 85%. So it seems like such a simple thing, but sometimes just knowing how to address, these issues, it can just make your workplace much more pleasant and really benefit your patients as well.
And it's extremely important right now when we're trying to maintain our staff. And, if we have staff that are upset at the way they're being treated by coworkers, such as physicians, this is just going to give them another reason to leave. So obviously something we have to keep an eye on. I love that success rate. That sounds very promising at 85%. Let's hope that we can see this work in our own environment. And hopefully, as you said, Sue, this isn't very common, but it doesn't matter. Just losing one nurse because of one doctor in your facility could be very expensive to your business.
And then there was an article in U.S. News about pain management during knee replacement. The August 18th U.S. News & World Report has an article about a study reported in the Journal of Arthroplasty. The study, which was conducted by Dr. Park, an orthopedic surgeon, and his team at Houston Methodist Hospital, examined the efficacy of morphine injected into the shin bone during knee replacement surgery for postoperative pain control. This was done in addition to the general anesthesia and the regional nerve blocks, which are normally used. The researchers had already successfully used intraosseous infusions of antibiotics into the shin bone to reduce the risk of post-op infection, so they found it adding morphine to the IO injections reduced postoperative pain by up to 40 to 49% for 9 days. As a result, the patients were able to use fewer opioids in the 2 weeks post-op period. And I have to point out that the study only involved 48 patients, and it's not clear why a medication that's usually quick-acting but temporary was able to control pain for several days. But hopefully they'll be doing more studies to find out if this technique can become an effective tool for not only reducing opioid use, but, just making people more comfortable after surgery.
That's an interesting study and an interesting use of a drug in a different way than normally would be used, or an opioid in a different way.
Yeah.
So, very interesting. So moving on to some recent experiences, I did want to bring up a issue that was discussed during a one of our weekly Saturday sessions for our patron members. And again, to remind everybody that patron members of our program get invited weekly to our Saturday morning, about 10 o'clock Eastern Standard Time, online Zoom session with about 2 to 3, sometimes 4 surveyors on our team here, and to talk about things that are going on in their surgery center and ask questions. It's a great opportunity to interact with the hosts of the podcast here, as well as a lot of other experts in the industry. And we are talking this week about consents, making sure that you have all of the consents and how those consents are done. And again, Sue, as we talk about, this stuff is kind of obvious, I think, but sometimes people, especially administrators, don't even know what's going on behind the scenes until a surveyor comes out. So let's just make some things clear. So generally, there are 3 consents that are required in a surgery setting. The first is the consent to treatment, and this is the facility consent that allows the ASC staff to treat the patient. For example, start IVs, basically for the nursing staff to provide care. And then there's the procedure consent, which is signed by the patient and the surgeon, which allows the surgeon to do the actual procedure. And then there's the anesthesia consent, which is usually separate from the procedure consent. And it's there particularly when there is an outside anesthesiologist or a separate anesthesiologist providing like moderate or more advanced anesthesia services. So one of the issues that's come up recently is sometimes we find these consents being signed in the operating room, which is not appropriate at all, not appropriate ever. And then sometimes we also see them signed even before the patient has had the conversation with the physician or with the anesthesiologist, which is not appropriate either. It must be signed after the patient has discussed the procedure with the doctor, and often that conversation actually occurs in the physician's office, which is all right. But again, you need to make sure that conversation occurs before that patient signs that document. And if a nurse is asking the patient to sign, then they're signing as a witness. But make sure that it is clear that the nurse is not getting the consent. They're just asking them to sign that consent.
Saying that, kind of attesting to the fact that they've had that conversation with the physician.
That's right.
And double checking if they have any further questions. And if they do, then you have to get the physician involved again.
And same thing with the anesthesiologist. I've seen situations where literally the receptionist gets the consent for the procedure sometimes and the anesthesia signed at the front desk, which is totally inappropriate. So you'll always have to have that consent signed after that conversation. And as Sue pointed out, the importance of making sure the nurse doesn't go outside her scope of practice and imply that she is getting the consent from the patient. So things that I hope are kind of obvious, but you might want to double check in your own organization to make sure that the sequence is done properly. So let's take a short break and we'll come back and we're going to talk about an interesting topic about interoperability in the ASC setting.
When it comes to the financial outcomes of your ambulatory surgery center, it has never been more important to maximize revenue, tighten the time to bill and collect payment, and reduce denials from payers. Yet without a keen focus on your revenue cycle, it can be difficult to achieve the results your center needs to remain profitable. The revenue cycle experts at Surgical Information Systems can help. With revenue cycle services from SIS, you can improve the financial health and performance of your ASC. SIS Revenue Cycle Services takes care of all aspects of the revenue cycle, including compliant coding based on documentation, claim preparation and submission, claim management, accounts receivable management, billing follow-up, month-end reconciling and closing processes, standard and customized reporting, and patient portion due and/or balance management. By doing the heavy lifting, SIS Revenue Cycle Services leaves you to do what you do best: provide affordable, high-quality care. In addition to managing your revenue cycle, the SIS RCS team uses a 5-step process to monitor, analyze, and make recommendations for improvement to your revenue cycle performance. More than 50 ASCs enjoyed these results from SIS Revenue Cycle Services every month. Faster claim submission, shorter time to pay, improved AR follow-up, higher net collections, expert coding to meet exact payer requirements, and an overall more consistent revenue cycle. Visit sysfirst.com to learn how the revenue cycle experts at SIS can deliver improved financial health for your ASC. Again, that's sysfirst.com to learn more about SIS revenue cycle services.
So, Sue, we are in an environment right now where, of course, there's a lot of staffing challenges, a lot of turnover, staffing shortages. It has been very difficult. And this didn't just happen with the pandemic, of course. It just has been exacerbated by what's happened after the pandemic. And as a result of it, we're looking for other solutions out there. And of course, computers can help, but we often don't even know what software solutions are available. Or what I find interesting, as we talked about in this upcoming interview, is what solutions you might already have included in software that you've already purchased. And it's also important for us to remember that we need ongoing training on the software we have. As we hire new employees, sometime the previous employees hire them or other employees on your staff who might not be fully aware of all of the functionality that is built into these systems. So let's listen to this interview with Lindsay Hanrahan from SIS. She's the Vice President of Product Management, and she'll talk extensively about the different interoperability things we should be considering in the ASC setting. So, Lindsay, why don't we start by asking a question? What does interoperability mean in healthcare technology, and why should we in the ASC industry care about that?
Well, thanks so much, John, for having me. I'm really excited to be here with you today talking about this. It is really an important thing for surgery centers and for any healthcare provider, really. But in surgery centers, it just seems as though some aspects of this technology have not been adopted as widely. And they do really represent a lot of opportunity for cost saving and also for maximizing staff time. So making sure that your most important resources are able to spend their time doing the things that truly matter the most for your center. So one of the most obvious ways that integration can help is just by preventing the redundant entry of data into a software application. So in many scenarios, as you know, the data already exists somewhere along the way. So it's collected at some other point during the patient journey, and the facilities are getting that data today from sources such as a phone call or a fax or, some other human or more quote unquote traditional type of interaction. So if the data reliably exists somewhere, then integration can really help surgery centers by getting that data into your application without your precious staff time being spent manually typing it in. And so when you really consider the data that's done per patient, per case, over the multiplied times the number of cases that your center is doing, the time savings is very considerable. And in addition, you're also removing the risk of typos or missed data elements along the way. So it really does add up and make a big difference.
And re-entering that information, as you said, if an error occurs and you have to start over again and go back and get that data corrected, that adds an enormous amount of time. I remember a number of years ago, I did a study for one of the surgery centers I was working with, and that they found that the registration person on average had to, and 50% of the time had to change the data that they had preoperatively for a patient that came in there. That's an awful lot of misinformation that came in. If we can get that information much more accurately up front, we have a better chance of improving our operations and making sure we don't bill something inappropriately.
Exactly. Yeah. I mean, the downstream effect of having the wrong data in the application, in any of your applications, it really does impact the overall revenue cycle. And even, can prevent HIPAA breaches in scenarios where, you have an incorrect address or some other data point that's out of date, and you reach out to the wrong patient or reach out to a patient about the wrong type of follow-up. So lots of other reasons in addition to maximizing staff time that it really is important to be sure that you have it correct, of course.
So, Lindsay, the other thing that strikes me when we think about using technology to improve our systems and move away from more paper, isn't this going to end up being a little bit more secure?
Yeah, absolutely. I mean, I think sometimes when people are used to paper, the change management around that is hard. Like it's hard to let go of paper in some cases.
They like that that paper trail. Exactly.
Yeah. But really moving away from paper is really important from a security standpoint, as you know. Mm-hmm. So sometimes I really, when I visit centers or, am in a doctor's office myself, I'm really astounded that fax machines are still around.
We're still handing out fax numbers. I don't think I've looked at my fax machine for years.
Exactly. Right. So, providers still have fax machines. They're still doing a lot in paper through various means of exchanging it, still very telephonic, heavy. Mm-hmm. So really an integration makes sure that the data is only traveling securely from point A to point B. And it's a predictable, it's exactly the data that you are expecting to get in the scenarios where you're expecting to get it. So, it really ensures that getting data from point A to point B is done through a completely secure tunnel, right, and that both parties know exactly what to expect from that communication. So what type of data will be going through, what types of, validation checks are going to be in place for making sure that data is reconciled properly, et cetera. So it really does ensure that we're removing a lot of the risks that providers currently have by having paper laying around the office, having people have phone calls in front of potentially other patients or other staff members, and really just make sure that the data only exists where it really needs to exist and only among the individuals who should be viewing it.
So, Lindsay, that kind of brings up a regulatory side to this. Is there a compliance issue also with regard to this topic?
Yes, definitely. So integration can definitely help your facility achieve compliance in areas that are especially emerging. So as an example, with the No Surprises Act, as you know, it's very critical that surgery centers have the correct contact information for all of their patients, and they need to have that right off the bat. Yeah. Since they're providing the statements in advance of the case taking place. So again,
otherwise this could end up being a very, very labor-intensive process. It looks like interoperability here is probably, one of the ways that No Surprises seems to be like an almost impossible task to deal with, which really is why we're talking about this today. If we want to, that's a prime example of that.
Yeah, definitely. I mean, making sure, that your referring providers already have all of the contact information needed. So making sure that your surgery center has that on day one, as soon as they know about the case, is amazing. And will allow you to move forward with sharing the patient estimate efficiently as soon as you have it. The other thing that I think will be really interesting to see is, if we anticipate that ASCs are going to be treated as the convening provider, it will be interesting to see how we can leverage integrations to aggregate the different services that are being provided by other providers adjacent to the surgery center. So, whether that is physical therapy or additional lab work or visits by the provider in their office. As it's a huge amount to compile. Yeah. And CMS has put some time estimates to what they anticipate that being. And of course, some of that is also allocated toward generating the patient estimate and communicating that, et cetera. But a large part of it is definitely, pulling together all of that data and preparing that consolidated statement.
Yeah, and I don't think we have much choice. I think the ASC is just going to be naturally that convenient provider. It almost has to be. Just like a hospital will be with a hospital event.
Yep, I agree.
So, it seems to me like interoperability is definitely critical to an ASC, given where we're heading, that it is becoming the alternative care setting. For so many cases, we're seeing cases moving from the hospital to the surgery center in even greater quantities, especially after COVID. So that seems to be another push that is out there for us to move in this direction.
Definitely. I I mean, a couple other examples of how it plays out from a regulatory standpoint is that certain states are pushing forward with HIE requirements for surgery centers. So most of these programs were originally rolled out for other provider types or in other care settings, and the requirements for ASCs were deferred temporarily. And in some cases, they were then further deferred during COVID, just to not push forward with another burden for providers during a time when they were already so, taxed with a million other issues. So now that we're getting back to kind of a new normal, these are starting to go into place in certain states. And they do really have a great benefit from a public health standpoint and in terms of sharing data between healthcare entities. But ASCs in these states are going to need to submit their data to the HIE. So
let me just pause for a second there, because what you're just
Sure.
for our listeners, the HIE is referring to Health Information Exchange in states like New York, where that is one of those states that's requiring that, is one of the leaders in that movement. So I thought we all love using those initials, don't we, Lindsay? And I'm not sure everybody knew what they were, but HIE, Health Information Exchange. Yeah, definitely.
We love our acronyms. So, there are a lot of acronyms further built into the HIE. So in addition to, HIE, we have Health Information Exchange, and then the type of communication that is generally shared is known as a CCDA. So it's a continuity of care document. And usually that is basically just a summary of the patient's care, and it contains information such as their allergies and their known problems. And so for surgery centers, it would also include information on things like what procedures were performed. It may include an operative note and so on. So it is a standard format, but each state has nuances in terms of what they require and don't require in terms of data that's included in that transmission. So the other component with it too that's interesting is there's also a patient consent. So in some instances, that needs to be captured by the provider. And so the provider determines, and the provider system would need to determine if that should be sent to the HIE. In other states, like in Connecticut, as an example, patients actually go into a website themselves and opt in or opt out, and then that applies across the board for all of their care, regardless of care setting. So there are kind of some interesting differences that are starting to emerge there. And of course, those all play into the rules for how integrations need to be able to be flexible in abiding by those. I guess the last example that's kind of timely is just, as a lot of listeners are probably aware, CMS recently issued the proposed rule, and there is a request for comment on interoperability for ASCs in that. So basically that means that ASCs would need to have an electronic health record in order to participate in that level of interoperability, most likely. So, of course, we all know how these things go.
Yeah.
And
hopefully it'll be many years.
Exactly.
Hopefully I'll be retired by then, Lindsay.
We hope not. But I'm sure you hope you will be.
Yeah.
So, but it was interesting to see that them include that there and just start to put feelers out to surgery centers in terms of the level of readiness. So it will be interesting to see how that plays out over time.
Okay, let's get to the fun stuff, though. Let's talk about some real examples, though, of how this can actually play out in the surgery center. How are we going to help our poor, overworked, underpaid, and understaffed ambulatory surgery administrators and nurse managers deal with things on a daily basis? What types of interoperability is out there right now, and we can go into? And why don't you just kind of talk? Why don't we just go through, like, as a surveyor, I always go, the sequence, follow the patient right through. So why don't we just start by talking perhaps like what happens before the case is even scheduled, or before the case is actually performed? Sure.
So I can go on and on in this area, so be forewarned. So we talked a little bit already about inbound demographics, but that's definitely one of the most common use cases. Patients are originating from some other place always for a surgery center. So for many of our clients, that use case makes a lot of sense. And, there are different flavors of that can be implemented. So it can be anything ranging from the referring provider's office sends and then continues to be the system of truth for patient demographics, in which case, changes made there would continue to update your ASC software. Other times, centers really just want to receive the patient one time, and then they want to take it from there. So they want to know that as they change the patient's, let's say, address or insurance information, et cetera, they want to be sure that that is not going to be overwritten by the system that originally sent it. So there are all sorts of options in that regard for how that part of the workflow can work. But really, it is a giant time saver, and again, just frees up your team to do other things that provide patient care and focus on other things that are more critical and that are non-negotiable for a human to do. The other part that is pre-procedure is we are seeing a lot of interest in inbound case requests. So many centers, they do want to maintain control over their schedule, but they know that the referring provider has some details on, generally what procedure is going to be performed, with, of course, which provider, which block exactly. And so being able to send over a request instead of, going through the more traditional faxing, phone call, phone tag, et cetera, is very valuable. So basically it lets the physician's software send a case request to your ASC software, and then your team is able to review that case request and make any adjustments necessary, and then go ahead and book it or deny it.
Or move it.
Either scenario, but exactly. Yeah. And then the other piece that really nicely kind of moves into is overall case coordination. So once the case is booked, let's say, of course, there are lots of different stakeholders involved in moving the case forward and actually performing the case. So you can also leverage integrations to make sure that other stakeholders are aware that the case was scheduled, and they're also aware of any additions to the case or changes to the case over time. So anything from, coordination with the surgeons, anesthesiologists, maybe implant, vendors, implant suppliers, et cetera. So being able to message those different stakeholders on a real-time basis and keep them current with the real-time status of the case as it moves towards surgery or during surgery are all great advantages and all areas where integration and interoperability can really play a big role.
Yeah, and for our audience, think about that. I mean, some of you might have multiple schedulers, or those schedulers have other duties here. If they can focus on, instead of entering that data right from scratch, having all that data there, and their energy then can be focused on making sure that the schedule is efficient, that everything is available, and it also reduces the number of errors that you're going to have in data entry. And the information that was gathered from the physician's office and brought over to the surgery center there, as you mentioned in the very beginning there, anytime that you're transferring data from one system to another one, there's a possibility of error. So knowing how challenged we all are in timing and how often we rely upon these administrative type people to do this data, and those are just as hard to get a hold of now as nurses. This could be a huge impact on our operations. Yeah,
definitely. Another step prior to the case is just receiving the patient's history. So, any kind of pre-op assessment, of course, often that leverages clinical resources, which are incredibly valuable to centers. So being able to collect that information, oftentimes through a portal, or collect it electronically right out of the gate is great. Most systems now do have a portal component. So, you may, behind the scenes, interoperability is in some cases being leveraged to move that into the electronic health record. But we do have instances where a surgery center leverages a different portal, maybe as part of a larger health system. As an example, if they have a hospital affiliation or something of that nature, they may leverage a different portal. And in that case, being able to get the patient's history in terms of medications, allergies, conditions, that the patient is self-reporting, does have a very considerable and well-established return on investment associated with that.
Yeah, well, it reduces the risk of cancellation on the day of surgery. That anesthesiologist and pre-op nurses get that information way ahead of the scheduled date.
Absolutely. Yep. Yeah, and kind of alongside that, being able to have the medication information right up front, proactively check for any contraindications, and just confirming all of that with the patient in advance of the procedure is super helpful. The ability to send reminders to patients in advance over, texting is great, and make sure that, again, to your point, a patient hasn't had a large breakfast before they came in. Yeah. They discontinued their medications appropriately, and they know exactly what's expected from their side and what they need to do to ensure that the procedure is successful.
Yeah, and it seems to me too, like one major function in many surgery centers is that preoperative phone call the day before surgery to tell them, to remind them of some of these things and to tell them the time of surgery. Those are all functions that don't necessarily need to be done by a human being, unless there's a question that needs to be asked, between the patient and the surgery center. A lot of that can be handled through this type of automated system.
Or even just reinforced, if some facilities may want to be sure that they've directly reached the patient or whoever will be responsible for bringing the patient in. But, getting a text at midnight or something to that effect can make sure that when you look at your phone in the morning, you remember to not take your medication that morning. So many of us just do that when we're on autopilot for coffee, or hopefully not that morning, but can make sure that nothing inadvertently happens that the patient has forgotten about, or that their caregiver has forgotten about.
Also seems to me that this could also help us out with getting paid, right?
Oh, absolutely. So, well in advance of the case, making sure that you have real-time eligibility checking, that you've done that upon scheduling the case, and then often right before the case again, to make sure that the insurance is still valid. Being able to get information related to, prior authorization. All of those are, of course, really, really critical to the overall revenue cycle, and just making sure that, insurance is still valid the day that the patient comes in, and that you are going to get paid for the procedure. So all of that, traditionally had been done through various portals or by phone. And really, you should be able to go into your software and just click a button and see immediately what the patient's eligibility status is. So really a big time saver there.
Yeah, and again, reducing the possibility of having to cancel the case closer to the surgery, or finding at the last minute or after the patient's already been done that that you're not going to get paid for it, or you're going to have to go through other hoops that need to be taken care of. Moving on to the actual case, is there anything that we can do with current technology interoperatively?
Yes, so absolutely. So when the patient arrives and they're going through pre-op, making sure that, hopefully all of the information that you've collected is now already in your application, as we earlier discussed, but going through medication reconciliation and reaching out to, Sure Scripts as an example, make sure that the patient didn't forget to include something maybe that they have been prescribed as part of the information that they provided you with. So that piece is definitely critical for once the patient arrives. During the case, a really nice feature that integration can facilitate is integrating vitals monitors.
Yeah.
So instead of having to, look at paper and be looking at the monitor and having somebody distracted with capturing all of that, it can instead just feed directly into your electronic health record and into your system, and just bring your attention to any anomalies or anything like that. But really being able to ensure that somebody is not having to look at paper and mark that up during the course of the procedure is huge and really important for patient safety. Integrations can also help to facilitate receipt of images that might be needed for the case and bringing those up, or sending images back so to another provider.
For example, the primary care physician, right?
Yes, absolutely. And then, being able to communicate with family members during the course of the case, giving them a heads up when patients are coming out of the OR. During COVID, we saw a lot of facilities, as you know, where family members weren't able to sit in the waiting room. So being able to stay in touch with them and let them know, what time they needed to be ready to come back into the facility was a huge help.
I do want to say to our listeners too, I know that we're talking over each other just so that our listeners know we're having some technical problems with this today, and there seems to be a slight delay. So I do apologize to everybody about. We're not doing this on purpose. It is definitely one of those areas where we probably should get some better interoperability with our communication. Maybe we're demonstrating a bad example of this. So
exactly.
And it doesn't end, Lindsay, at the during the case, right? I mean, after the case, it seems like in many ways, this is the last contact you have with the patient, last opportunity to impress them. Yep. So it's just as important as before, and in some ways even more important.
Absolutely. Yep. So as they head home, being able to provide discharge instructions as an example. You may provide those to them in a hard copy when they're leaving, but being able to send those electronically, either to the patient and or to a caregiver or a family member is great, just so that if you lose that piece of paper, the patient or their caregiver can easily access that online. A very popular use case is sending data out to transcription companies or software. And then also, receiving the transcription back into the chart, or also, for centers who complete the op note just directly within their EHR, being able to send the op note back to the surgeon's office or to any other providers really does automate a process that has many, many steps if you go through it manually.
And prone to error. Exactly.
Yeah. Yep. In terms of, sending it to the wrong destination, getting any of those data points wrong.
A big issue also in surgery centers, and this technology has been around a while, but we're not always using it, is pathology. We're finding a lot of, as a surveyor, we find a lot of places getting cited for not having an acknowledgement that the patient had been informed about the pathology reports. And again, this is a great example, isn't it?
Definitely. As well as just getting those results back into the patient's chart. So kind of multiple different scenarios there where pathology integration is a big help. Okay.
And I hate to keep getting back to money, Lindsay, but after the case is done, we have a lot more to do, don't we?
Absolutely. Yep. So being able to, of course, claim submission, can most listeners are aware that can be automated. But also the ability to check your claim status from within your software is very important and a helpful tool to ensure where that payment is in the flow, and ultimately being able to accept the payment electronically and have that post back into your application. Huge time saving associated with that part of the workflow. And then, all along the way between claims and payments, we have, statements going out and reminders of statements.
Yeah.
So all of those can be fully automated.
When I think back on everything we've talked about here, there's just so many different. It's not like there is one big item sitting there. It's like a whole bunch of different functions that the average administrator, director of nursing, is going to be challenged to find. And I think we're so busy dealing with the day-to-day crises which pop up. We're so busy with just making sure the patients are taken care of. Often we don't have time to plan to go through and look at every part of that operation. I think just seems to me like this is something that, an administrator and a nurse manager should sit down and, maybe break it into chunks over a couple week period where they just look at every aspect of that operation, of their operation, and try to see which areas are ripe for moving toward a more automated option. It strikes me too. I think one of the great things about you're doing this with us today, Lindsay, is giving, it's almost like a brainstorming session, throwing a bunch of ideas out there and saying, hey, listen, this is available in the marketplace. You might be able to find a provider that can do this for you, or, a total solution like, for example, our sponsor SIS, provides. Just making sure that you are always aware of what's available to you, either, within existing software that you already have or software that you might consider in the future.
Yes, definitely. So, I mean, as we discussed, there really are a huge number of points during the patient journey where, and the case flow for the facility, where integration comes into play. And really for your staff members, all of this, they shouldn't have to think about any of these things once the integration is in place. They should be able to search for an item that they're going to use on the case and know that it is retrieving the current price for that item, for example, or, the current number of quantity on hand that you have for a given item. So all of these things should be, once they're in place, should be natural in the course of your staff's workflow. But it really does add a huge value to your surgery center, and can really, end to end, really expedite the overall revenue cycle for each of your cases, which again, like we talked about earlier, when you multiply that across all of the cases that you handle in the course of a month or a year, is really huge. So as you said, John, I mean, I think that as centers sit down and they think through, what are the areas where humans are doing a lot of work that really don't have to be done by a human.
Yeah.
If the data exists somewhere else, you should be able to get it into your system without a person having to retype or recapture or upload or download the data to and from various other applications. And really, like we talked about earlier, that makes sure that all of the data is exchanged securely, it's accurate, and you're not wasting any staff time, and your staff can spend time with patients and making sure that they're ensuring the best possible patient experience, and also experience for the surgeons and the rest of your team. So letting them focus on the things that really matter.
So Lindsay, I've always felt, and I think you and I have talked a little bit offline on this, that we're kind of late to the game in the ASC industry, aren't we? I mean, many other industries or many other parts of the healthcare system have already done what we're talking about. It's almost like if we were talking to a hospital about this, they would say, what are you talking about? Didn't you already do this? Or even some sophisticated physicians' practices. Are we late to the game?
Yes. I mean, yes. So hospital systems and physicians, practices did need to adopt at least some basic integration and interoperability as part of meaningful use. So since surgery centers were not included in meaningful use specifically, and still are not thus far, those same requirements have not been enforced on surgery centers. And, it really is part and parcel of the lack of a requirement for EHRs in general. I definitely do think, though, that, when you look at where ASCs are situated between physicians and their practices, and sometimes a hospital, which may have an affiliation with a surgery center or surgery centers, we sit in between them in many instances. So because all of those surrounding systems have meaningful use certification and therefore have integration and are already doing this as part of daily life, really it does mean that your surgery center software does need to be able to communicate with those other systems to ensure that all of the patient data can, flow efficiently. Everybody has what they need. They have it quickly. In many cases where a surgery center has an affiliation with maybe a large healthcare organization, in some cases that healthcare organization wants them to actually use their software. And in some cases, it's really overkill for what the ASC wants or needs. Also has a very different price tag. So instead, being able to use software that is designed for a surgery center while also just communicating with the surrounding applications offers a really good kind of middle ground so that your staff has the software that they want to use, and they have it's kind of the Goldilocks scenario of it being the just right size software, but can still meet the requests or in some cases the requirements of other stakeholders that your center works with by being able to efficiently share data with those other parties. So, yes, I definitely think surgery centers are late compared to, some of the adjacent care settings. But the good news is, overall in our space, there are a lot of new choices for software providers. All of those have integration as core components and as a core part of their value proposition. So I do think that we'll see a pretty dramatic increase in the use of integrations by surgery centers in many of the different areas that we just discussed.
So how do we start? So for the again, that poor overworked administrator or nurse manager, what's the next step that after they listen? So they're probably on their way to work right now as they're listening to us. What should they do as soon as they get there, other than, of course, put out all the fires that just, started flaring up?
Sure. So, definitely just reach out to your software provider and find out what workflows are provided, what workflows are supported. What do you need to do to learn more about those? They should be able to, even if you're not really sure which one to tackle first, your software provider very likely has a team of people who can talk you through some of the options and help you and your staff determine where you might have kind of the biggest bang for the buck in getting things going. And, you can always just expand from there. So, prioritize a list of workflows where you stand to gain the most, and you can tackle them with your software provider over time.
And look for that low-hanging fruit. Yeah.
Exactly. Yeah.
Yeah. And, one observation that I've had over time working with all the software vendors is that so frequently the users, especially with organizations that have a lot of turnover, like you as the administrator, you as the nurse manager out there, you might not have been part of the original training for that software. So you might not be familiar with it. You might have not even come from the ASC sector to be aware of what that software can do. And, let's face it, Lindsay, not all the time do, when a new administrator comes in, you don't send somebody out there to train that new administrator how to use it. I always emphasize the importance of, on a regular basis, recommunicating with your vendor to find out, what options are there that you're not using that maybe put off into the future, and then but that future never occurred because somebody else is in the office that wasn't there when the software was originally installed.
Absolutely, yeah, that's a really great point. And also just to be clear too, we've talked a lot about some of the newer products that are available in the market. Pretty much all of the older products also have many of the capabilities that we talked about. So, and sometimes people, like you said, just don't think to ask. They're busy doing their normal daily routines and covering so much ground. Surgery center, especially administrators, clinical directors, they do a million different things over the course of a day. Yeah. So this naturally is not the first thing that they're thinking of, but again, if you talk to your software provider, they'll help you to understand what options are available, regardless of which application you use, and can really help to provide some direction and where you might gain some immediate benefit.
Lindsay, this has been a pleasure. Thank you so much. Hopefully our audience has learned an awful lot. I think you've just given a big checklist of things to do. There's certainly a lot to tackle in the short period of time that we've had to talk. But thank you so much. We'll provide your contact information if anybody wants to send you an email or give you a call. I'm sure you'd be available to them, correct?
Great. Yes, thanks so much, John. Definitely feel free to do that. And thank you so much for having me.
No problem.
In this segment, we provide an update on upcoming topics for the podcast, our upcoming virtual conferences, and upcoming speaking engagements for John and his staff, and other events in the ASC industry.
So as we mentioned earlier, CASA's annual conference and exhibits is September 7th through the 9th at the Hyatt Regency Indian Wells Resort and Spa in Indian Wells, California. And I'll be doing a 4-hour finance boot camp there. I think you can still sign up, so go to casurgery.org for more information.
And September 15th through 16th is the ASC Finance, Accounting, and Reimbursement Seminar that will be held virtually with John and Christina Benton of Coding Compliance Management.
And for more information, visit ascpodcast.com. And then OR Excellence Conference is September 29th through October 1st, 2022 in Orlando, Florida. Ann Geyer will be speaking, and Deronda Vaught will be sharing her work on creating a culture of safety.
The ASC Director of Nursing Boot Camp for nursing leaders in the ambulatory surgery setting. Like all of our industry-leading boot camps, the Director of Nursing Boot Camp includes reading materials, virtual mentoring consultations, and an intensive 4-day virtual conference to be presented October 25th through the 28th, 2022.
And again, for more information, ascpodcast.com. And ASCA 2023's winter seminar is January 12th through the 14th at Caesars Palace in Las Vegas, Nevada, and I'll be presenting there. I don't remember yet, Sue, what I'm presenting. I think it's another finance seminar, so definitely go to the ascassociation.org website. And don't forget about our recorded events also, all available on ascpodcast.com, which includes our credentialing conference, the Fall 2021 Finance and Accounting Conference, Conditions for Coverage Conference, the Medical Director Conference, and the different self-paced versions of our Administrators Boot Camp and Director of Nursing Boot Camp. And we do want to remind everyone to become a patron member of the podcast. The Patron Member Program, which is also known as ASC Central, is an exclusive membership website that provides a one-stop ASC regulatory accreditation, compliance, operations, and financial management resource for busy administrators, nurse managers, and business office managers. Resources include some of our virtual conferences, links, policies and procedures, forms, drills, discounts on services, and books, and access to AEU credits. Membership helps defray the cost of producing the podcast, including research staff, travel costs to conferences, equipment costs, and production costs. For more information, you can visit ascpodcast.com. Well, that's it for this episode of the ASC Podcast with John Goehle, and please spread the word about our podcast with your friends and colleagues, and do us the honor of hitting the subscribe button. The sound editor for this episode is Susan Cronkite. Executive producer is John Goehle. Research assistance is provided by Susan Cronkite, Jenna Alvarez, Judy D'Ambrosio, Alex Borneman, Zach Calritis, Amy Durbano, Lori Rodericks, and Ann Geyer. Music is provided by Media Sushi and Mike Noah. And the ASC Podcast with John Goehle is hosted on Podbean and is available on all major podcast channels.
This episode of the ASC Podcast with John Goehle is sponsored by Surgical Information Systems, SIS. SIS's mission is to deliver solutions and services that help surgery providers, regardless of care setting, improve their organization so they can deliver the highest level of care to their patients. For more information, go to sisfirst.com. This podcast is an educational and operational tool and is not intended to be a comprehensive resource for all rules, regulations, and standards that an ambulatory surgery center must meet. The advice provided should not be considered as, nor does it constitute legal advice or opinion. When reviewing specific situations involving legal and regulatory issues, attorneys and other professionals should be consulted. This has been a production of Eden Group Development. All rights are reserved. If you're interested in advertising or sponsoring the ASC Podcast with John Goehle, please email us at info@ascpodcast.com. We would love to hear your questions and comments. Please email us at comments@ascpodcast.com.